So, we all know Dr. Feyrer-Melk. So she's the brains behind all of this. She's the one that, some of you have heard the same example with how I explain how we work together is, think of your computer, and in your computer there's always a virus protection program running in the background. You really can't figure it out, but it's something, and all of a sudden you get a pop-up. You gotta clean something out. So she's the virus protection program, okay? She's working in your bodies behind the scenes, checking things out. And then I get to be the fun apps. I'm the fun apps up the front. There's the stuff that's the why you want to do something. It's the things that you can do because of the things you do with her. So, and she always says that the best medicine is on my side of the aisle. I think they definitely work together because it's on the inside. It really matters. So without further ado, Dr. Feyrer-Melk. I think so. Did I grab the... Yep, here it is. Oh, is that it?
There's another one.
Oh. There we go. There you go.
Thank you, Dr. Steer.
Yes.
And I
Sitting
didn't
on the
get the
couch
chance to say
tonight.
hello to absolutely everybody
that's
that
still
came
on.
in. So if I miss giving you a hug, I'm giving you a hug now. Okay. Thank you all so much for coming tonight. And I need you to buckle up because I want to go through some of the research that just since we were here a year ago for Heart Month last year, I want to go through some of the 2022 research because this is just incredible stuff that applies to you guys, okay? And so here we are in our world, and one thing that some of you may start to say is that when we really dumb down what we need to do for our health, this is my mantra now. Eat plants and fish and move every day. It sounds so simple. Why is that so hard to do? But if we can eat plants and fish and move every day, that's just like a nice baseline for us. And as we go through this talk, we'll add things on. I could add on a couple hundred things off the top of my head that we can put onto this list. But let's just keep it simple throughout the rest of this talk, okay? Because here we are, healing arteries, and I'm telling you that your arteries are cold, and we're so excited about that. And then you plateau with your meds, and we take away some of your medicine, and then we lean maybe a little bit harder on subs instead of the prescription medication. And we're just in this real llama land of healing in my office. But that is not the real world. Let's look at August 2022. And I was really excited when Jack came up with this. So the Journal of the American College of Cardiology is my Bible as a cardiologist, okay? So we followed their guidelines. And they gave some predictions for future cardiovascular disease. And I'm thinking, wow, we've got all this stuff to do that we can heal arteries. Let's see what's going on. So this is from Mass General, published in August 2022, and what they did is they looked at, from 2005 to 2060, what the heck is happening with cardiovascular disease in the United States. Doesn't look good. I mean, we've got 25 million new patients that are going to be diagnosed with cardiovascular disease. That's a 30% increase. And I'm thinking, give me a break. We know how to prevent this stuff. What's happening? Let's look at heart failure. Increase of 33% in congestive heart failure. That is the #1 diagnosis for hospitalizations in the United States, CHF. Okay. Then we look at heart attack rates. You think that would be going down, right? Nope, up 17%. And then we look at stroke, the highest increase, 33.8%. And it takes my breath away. Because why are all these increases happening? Cardiovascular disease, heart failure, heart attack, stroke. Because we're losing control of our risk factors. Let's talk about them. Diabetes, an increased risk of 40%. That's almost every other person in this room. Of course, you're not going to have that happen to you because we're preventing it, right? But this is what we're looking at in the general public. Look at these numbers, these millions of people. High blood pressure, increase of 30%. High cholesterol, increase of 28%. This stuff's preventable, and we're still these massive increases. Obesity, increasing 19% almost. This is preventable. Heart attacks, strokes, and diabetes are preventable. So, but we're dealing with the outside world, right? So we have to use all of our techniques and technologies and try to apply them to ourselves to prevent this from happening to us in our world, right? Heart attacks, take a couple notes. You guys are setting examples for loved ones. You have knowledge that they don't have. There's an exuding effect that you're going to have on other people. A really simple thing to do to suggest to a loved one for heart attack prevention is say, hey, go get a calcium score. Pay cash for it, just go down to SimonMed and do it, and the only normal score is a 0, right? We've all heard this, and some of you guys have 0 scores. Okay, if it's a 1 or anything above that, you've got heart disease. It's a simple no-brainer place to start. Last year, I told you, even patients with 0 calcium scores, up to 47% of them can have some small plaque, and that's happened to a couple of people in this room. But at least this is a good starting point for screening. For screening for a stroke, have them grab a carotid thickening test, a carotid IMT scan. They can pay for that locally, or how much is it for us at our office if someone walks off the street? So $400, I can get a carotid IMT. You don't have to be a member to get an ultrasound of my test. If they want to come and do that, I'll sit down and talk with them, and I can give them the results. Diabetes, completely preventable. My gosh, we screen in so many different ways for diabetes and pre-diabetes, and we're nuts about it. That oral glucose tolerance test that everybody loves with the sugar drink. Other people can get that done too, so you can have this educational effect on loved ones when you're looking at some of these dire numbers. That's over the next 25 years. I mean, that's the rest of my career, my life, and it's a good part of the rest of yours too. We've got to prevent this stuff. Eat plants and fish and move every day. Let's look at November. Talking about fish, American Heart Association, EPA fish oil trial. We've got some exciting stuff here because I know you guys love it when I check your EPA level. We're talking about those big capsules, right? This is the Respect EPA trial that just came out. It's brand new. And what they did, now they looked at patients who were all on statins. Some of them had the appropriate levels of EPA and some had no fish oil at all. Okay, so these patients were on statins. I just want to point that out. But above that, there's 26.6% reduction in sudden cardiac death, in heart attacks, in unstable angina, and coronary stenting of the arteries in the patients who were on the right amount of fish oil, okay? But this is the EPA only fish oil. This is actually the 4th trial. There's Jealous, and then there's a trial called the Reducer trial. I've given you flyers about that in the past. There's a Japanese trial. This is the 4th trial now that shows death reduction benefits in cardiovascular disease if you've got the right EPA. Now, you're not going to like this, but the combination products, they have both EPA and DHA in them, and you can look at the back of your fish oil label when you go home. The combination products don't show that heart benefit. It's the EPA only trials. Okay, so just food for thought with that. The EPA only products are the only ones that show benefit in cardiovascular outcomes as far as death reduction benefits. And you know that you're sitting in my office and I'm always talking about death reduction benefits. It sounds like a scary thing, but that's what we need to do to combat some of those statistics we just looked at over the next 25 years. So the dose of EPA is actually higher than what I've been quoting you in the past. So the new gold standard dose for EPA is 1,800 milligrams per day. Not the DHA, not the combination. Don't look at the front of the Kirkland fish oil, right? You gotta look at the back and see what's the serving size of your EPA, how much are you really getting in your body. And then what I'll do, because that's not good enough, right? Then what I'll do is I'll check your bloodstream and I'll prove it to you that you're normal. You want your EPA greater than 2. Death reduction benefit. Eat plants and fish and move every day. So let's talk a little bit more about moving every day, because man, you can't turn on the radio without hearing about Relief Factor. Probably some of you guys are taking this stuff. It's $94 a month to take the Relief Factor. It really works. Let me show you the blown up version of this back label. What? EPA? There it is, as an anti-inflammatory for your joints. It's really cool. I've told many of you orthopedic doctors sell fish oil in their practices for joint pain, okay? Ophthalmologists sell fish oil in their practices for eye lubrication. So we want to be well-greased machines. And if you have Relief Factor at home, you can look at the back. 2 of those soft gels are EPA. There's some DHA in there too, so again, we don't get the death reduction benefit, but you're getting the anti-inflammatory benefit, that may help you move. Now let's look at the other 2 capsules that are in the 4 that you take per day. There's curcumin. Many of you are on curcumin. Why? Because you either have inflammation in your arteries or your telomeres are too old. So many of you in this room are taking some curcumin. Usually I start at like 500 milligrams a day. Many of you take 2, then you're kind of getting what's in relief factor, right? Resveratrol. If you've got plaque, I've got you on resveratrol. Because that has some soft data for plaque regression. It's cool stuff. It's also anti-inflammatory, so that's why it's in relief factor. And then the horny goat weed, that's also for joint pain, and it's also for libido. So that's not something I normally prescribe, but you're still getting 3 out of the 4 ingredients. Can save you a bunch of money with instead of taking your relief factor. You're probably on it.
Is that horny goat weed legal in this state?
I kind of didn't want to bring that up to you, Dr. Steve, but okay, let's keep it simple. Plants, fish, move every day. We want to keep that movement going, whatever we can do. We want to attack any joint issues along the way, get you in to see the right people, keep it moving every day. Let's talk a little bit more about that, because Dr. Steve and I talk a lot about getting at least 150 minutes of cardiovascular exercise per week and up to 300 minutes. That's the guideline. That's an hour, 5 days a week. That's a lot. But look at this study just from September 2022 with walking, European Society of Cardiology. This is attention to my older patients, my treasured older patients that are my role models in life, okay? 10 minutes of walking a day cut death rates in octogenarians. So that puts the rest of us to shame if we're not moving every day. I mean, you get death reduction benefits even with small amounts of this stuff. Move, move, move.
Hey, I'm a football player. What's octogenarian?
The patients in their 80s.
Thank you.
So, plants, fish, move every day, okay? Let's talk about some fun stuff. March 2022. We talk about dark chocolate every single year, I think, because it's so cool. But now this is actually the largest and longest randomized double-blind placebo-controlled trial, so this is good science, looking at daily cocoa, dark chocolate, to prevent cardiovascular disease. There's a big study, 21,442 patients, followed for 3.6 years. That's it. They weren't studying these people for 20 years. They studied them for just shy of 4 years and had benefits. 500 milligrams of flavonoids a day, that's about 7 to 10 grams of dark chocolate per day. Reduced cardiovascular death rates by a whopping 27%. Think of those dark slides I showed you, of the trends that we have going. But for heaven's sakes, can we eat plants and fish, move every day, and eat chocolate? Yeah, that's pretty cool. You want food as medicine, right? Food is medicine. Let's talk a little bit about other polyphenol groups. Black tea. Been hit some of you hard with this already, especially with the telomeres. If you've got any lengthening in your telomeres, I'm asking you to consider having more tea. Green tea, of course, is superior in many ways, but this was the European Cardiology Congress again. Up to 30% lower risk of death with just 2 cups of black tea per day. 2 cups. Or you can have 1 large cup, right? That's Starbucks. Reduced heart attack rates, reduced stroke rates, and in this study, adding milk or sugar did not affect the results. If you're pre-diabetic, we want to take a peek at that, right? Just watching that. Polyphenol group, chocolate, dark chocolate, tea, coffee, okay? Those are heart-healthy things to have. So you can add that onto your list. Plants, fish, move every day. And your polyphenols that you love so much, okay? They're medicine. Okay, now we're a little beat up after all the vaccine stuff, but what's happening is that we're not getting up some of our routine vaccines. You hear a lot about this with kids, but it's like this with adults too. And one place that we've slipped a little bit, and so Jack, again, is coming out with new guidelines in 2002 for shingles. So shingles is the chicken pox that you had way a long time ago, and those little buggers are still living in their nerve roots. When do they like to come out? Under times of stress. I have a daughter who's a second year medical student. Of course, she's right before her final exam. She's like, Mommy, is it normal to have a rash coming down the front part of your face? I'm like, oh my gosh, send me a picture. Shingles right down, aiming right for her eye. Those are the dangerous types of shingles. But shingles in general is a very painful outbreak of blistering. It tends to follow a dermatome, like in your thorax or on your arm, something like that. So shingles is tough because you can have a syndrome afterwards where you have a lot of hypersensitivity and pain. You want to prevent it. If you've ever had it or you know someone that has it, you know how awful it can be. 1 in 3 adults will get shingles after age 50, and by the age of 85, half of patients will have at least one bout of shingles. And we really want to try to prevent this, because one bout of shingles, in my selfish way of looking at it, is going to increase your chance of having a stroke in the next 12 years by 38%. That's a huge increase, and an increased chance of having a heart attack over the same time frame of 25%. Why? Think about it. Chronic inflammation, right? We're measuring all those IBMs, those inflammatory biomarkers. The first page is the worst page on most labs, right? That's that top category that I'm always hounding you about. This is what shingles does, is it impacts that inflammatory cascade. So we need to think a little bit more about the Shingrix, and many of you have had this already. But if you get the Shingrix vaccine in your 50s and 60s, it's 97% effective in preventing a shingles attack, which is huge. That's a huge success rate. And even if you're above the age of 70, you get it, it reduces it by 91%. So it's very worthwhile doing this. It's 2 shots over 6 months. And the CDC recommends that all adults greater than age 50 get the shot, even if you had the ZOST effects in the past, or even if you've already had a prior bout of shingles, okay? And as of last month, there's no charge for Medicare Part D patients. Just a little perk. Plants, fish, move every day, right? Okay, now, this is really big because in 2022, we have a new category of cardiovascular disease risk. I've already assessed a couple patients this past week. One of you is here today to look and see. I've got the guideline right here on my desk to look and see who are my high risk, my very high risk, I should say, patients. And it's about 50%, 55% of all patients with cardiovascular disease, unfortunately. So who are they? The very high risk patients have had a major event. They categorize it by a recent heart attack in the last year or any history of heart attack, okay? A history of stroke, or if you've got leg blockages that are giving you cramping when you walk, especially the back part of your legs when you're ambulating. Those are major events. The very high-risk patients, another category is major event with multiple high-risk conditions. This is a lot of us in this room. Age greater than 65. I don't take smokers in my practice. It's one of my screenings, just FYI, so no, there's no smokers in here. Prior coronary artery bypass, grafting, stenting, hypertension, diabetes, kidney disease, congestive heart failure, uncontrolled L is for lousy, you want that one low, the bad cholesterol greater than 100 on therapy, and the familial hyperlipidemia gene, which is very rare. I just have one patient with that gene. But those very high-risk patients are 3 times more likely to have a heart attack or a stroke. So I need to treat them tenderly with a very aggressive eye, because look at this, 2022. In the past, when we would get your standard lipid profile, I'd take that LDL number. If you've got plaque, I'd say it needs to be less than 70, right? We'd rip up the labs and I put that on there for you. If you're a high-risk patient, now we're ripping up those labs. We're saying they've got to be less than 55. That's hard to do. Now these are guidelines, and I've told all of you, I need to pay attention to the guidelines, but you are an N of 1. So I will put this in perspective with your genome. If you're an ApoE44 or an ApoE34, like me, it's going to be tough, right? So we have to really, really be paying attention to these lipid profiles. If you're ApoE23, then you're probably eating cheeseburgers and bacon and getting away with it no matter what your spouse does, right? So we have to look at these labs and see what's happening there. That we have to put it into the phrase of the N of 1, okay? Do it on a genetic platform. But this is really big. So controlling this blood fat problem, especially in those patients with those genetic risks, is really important. So get ready, buckle up. Plants, fish, move every day. If you can't move every day, you should feel a little guilty. Unless Dr. Steve, when he does your testing, finds out that you need a recovery day. Some of us are lucky enough to need a recovery day. We don't have to do anything. That's the only day you get to do it. Okay, the ProBNP lab test. I often call this the happy heart hormone, And I'll write on your labs that it's a sign of an overworked heart. It's protein that's released that regulates the blood circulation in your body. And it's really becoming front and foremost with some of these new guidelines here. So congestive heart failure, again, the number one reason that patients are admitted in the United States, has lots of symptoms, but the big one is always going to be shortness of breath. Okay, so 98% of patients who have congestive heart failure have shortness of breath. Fatigue is tough because 60% of those patients will have it, but fatigue is hard because did you sleep badly? Are you dehydrated? Are you stressed? There's a lot of reasons for that. If you've got swelling in your ankles, we're watching that. That could be a sign of congestive heart failure 45% of the time. And if you have something called orthopnea, when you feel short of breath when you lie down flat, that can be a sign of congestive heart failure. And then there's a lot of other ones too, like coughing and wheezing for no reason, feeling lightheaded, you're up urinating more often than normal, and your exercise capacity is going down. These are all just symptoms of congestive heart failure. So the big question I always ask is, do you have anything going on in your chest? And so it's a shortness of breath is one of the big things I'm getting at with that. Because of this. So this is so huge. We didn't even have this when I was in training. Okay, this is heart failure with preserved ejection fraction. Some of you in this room, I've written this out for you on your labs. Okay? Because what it is when we do your ultrasound, your echocardiogram, Mary's here today, so she knows all about this, the sonographer, you have an ejection fraction that's normal. So I would say to you, your ejection fraction looks like a teenager. So most of you have heard that. Okay, your ejection fraction is normal. That's the percentage of blood that your heart pumps out in one beat. Okay, so it's greater than 50%. But this new category, heart failure with preserved ejection fraction, actually accounts for half of all heart failure cases. Well, I just showed you in the first couple slides that heart failure is going rampant. We're increasing by 33%. Even since up to 2060. This is horrible. Number one reason that people are admitted. Lots of morbidity with this. Lots of painful living with congestive heart failure. We need to prevent it. And so if you've got those sorts of symptoms, and if you have any stiffening or thickening of your heart, I would tell you that. I'd show you this is the thickening of your heart wall. You've got some stiffening with it. And you have this BNP number that we check on everybody every 3 months because it's so important. If it's going up above 450 and I'm going, we can see what's going to happen. Maybe reduce your sodium a little bit. Let's look at your echo again. Let's see what's happening with your valves. Are there other reasons? But if it's above 450 consistently, it's 85% specific for this heart failure with preserved ejection fraction diagnosis. Okay, it's nasty, but I need to diagnose it with you. This is the population, these healthy people. This is the population that we see this. So I can get you treated. Because, let's look again, the big Bible groups, American College of Cardiology, American Heart Association, Heart Failure Society of America. It doesn't get any higher than these groups. They have a consensus statement out now that's less than a year old and how to manage this. So how do we do it? Well, for heart failure with preserved ejection fraction. In this room have this. Oh, you're done. Diuretics if you need it, like Lasix and furosemide. Then there's a medication called Jardiance, which is typically used for diabetics. Some of you are on this medication, we use it for diabetics. It's awesome for arteries. We gotta watch Jardiance because there's gonna be so much research coming on that might be helpful for arteries in other ways. Entresto, some of you are on this. You certainly see it on late night TV. It's expensive, it's got side effects. It's a great medicine for this problem, okay? There's the rigmarole because we have to take you off of your ACE inhibitor. It's a kind of a mess. Then we put you on spironolactone, which is another type of diuretic. And then we say, okay, your heart muscle is normal. You squeeze like a teenager. Now you really need to exercise because exercise is great for this category of people. Okay, so we're going to be hounding you. I'm going to tell Dr. Steve, this is an HFpEF patient. We need to get this patient moving. Let's get her going, or else we'll put you in rehab if you can't do it by yourself. We need to use that as medicine, your best medicines across the hall. I don't want to give patients this stuff. This is expensive, they've got side effects and stuff. We need to prevent these sorts of problems. So let me screen you, but we need to prevent these sorts of problems. How do we do it? Eat plants and fish and move every day. And chocolate. Thank you.
Wonderful, wonderful, wonderful. We have time for questions. Here's a question right over here. Can I get the